Yes, we can.
Yeah. How are you all doing it, the assignments? Hello. Has anybody started writing? Okay, it's 8:30 now. We have about 1/3 of the participants. So if Lean has joined, we can start neither Shashi.
Yeah, she has joined. Lihin is here.
Yeah, everybody's joining. Are we going to wait another 2 minutes or start? People are still joining. Today morning, one has queried that now in the what we shared about the assignment, it at one statement there was you have to type in Times New Roman, and then the very next the sentence, it says it should be on in your own writing. So by writing we mean it's it should be on in your own typing. Actually, you don't have to uh, literally write. So all writing happens in typing now. So just do your own work. That's it should be your original work. So that's what we mean by that. I mean, we are actually not going to test it or plagiarism, but if you copy and paste, we will see that because we will be manually marking these. And it's really ugly if you uh, copy paste from here and there, and I mean it's really a mess. So I mean it's okay to get the idea and just rephrase it, Anybody has any questions about the assignment so far? Has everybody chosen a case?
Sir, does it need to be a chronic wound, or can we write the assignment about an acute ulcer as well?
Now the thing is, now is how are you going to explain the wound biology of the acute wound? There's nothing much to write, no? It's okay. I mean, you can take a acute case. Then you'll have to just explain all other stuff in theory. So the point is that to you all to regurgitate everything that we have taught and use the jargon and do what we asked you to do. Say to explain the wound using the template we gave you, and to show that you are looking at the wound the way we explained. Say in terms of wound biology, in terms of wound bed preparation, in terms of how to choose the best dressing and all that. Is that
Okay.
clear?
Yes, sir. Thank
It's
you.
better to be a chronic wound, but if there are no chronic wounds and if you have an interesting acute case, take it. But you have to say rewrite everything what you have told you in theory. So you can say that, I mean, these things are there, but since this is a acute wound, it doesn't apply here. But what applies here is the intention of healing right now, whether it's primary closure or secondary intention. Let it heal on its own, or are we going to intervene and is it going to be tertiary intention or delayed primary closure? Is that
Okay, sir. Thank you.
right? Okay. Anyone else? It's better if you can start writing at least midway and finish it off by the end of the course. Okay, we have about 69 people. Shall we start, Shashi?
Yes, I think we can.
I'm just trying to share my screen, but it says that I can't.
Hitira, can you help?
It
Okay,
says
I'll,
post disabled participant screen sharing.
Hitira, වෙනස් කරාද?
I will do. Wait,
All right, thank you.
Shashi, can we officially start introducing the speaker?
Yes. So welcome for the third session of this workshop. This is the
Yeah,
third one,
is that
no?
thing I paid
Yeah.
for? Wounds lecture?
Hello?
Somebody's mic is on.
Yes, and so we will start. So our first presenter is Dr. Lihini Wijeyaratne. She's a PhD, she's sitting for a PhD, and she will be briefing you on the basic concepts on palliative care and the role of wound care in palliative care. So over to you, Lihini.
Thanks. I still can't share my screen.
Hitira, what's happening?
Uh,
I think she can.
yeah,
yeah.
no, I can. So you can see my screen now?
Yes, we can see now.
Thank you. So thank you for asking me to speak today. I'm Dr. Lihini Wijeyaratne. So my task is to introduce the basic concepts of palliative care to you and how they relate to wound care. And then after that, there will be more detailed lectures about wound care itself. So in terms of what palliative care is, this meaning of palliative care is always being updated, and it depends to some extent who is providing it and where it is being provided. But this is a recent definition, and it is defined as the active and holistic care of an individual across all ages who have serious health-related suffering due to a severe illness, which includes people near the end of life. And it aims to improve the quality of life, not just of the patient, but also of the people around them, so their family and the people who are looking after them. So if we just go through this definition a bit, one thing is to say that this is active care. So sometimes when we say palliative care, people will think that that means we have given up on the patient, that there's nothing left to do, that we're letting the patient die in a way, and that we are stopping doing a lot of things. And as doctors, we can sometimes feel like this is a failure of care. But this is not actually the case, because there is a lot to do in palliative care, and we'll touch on those things a bit later. So it's an active process where we are reducing suffering and improving the quality of life. So this is done in a holistic way, meaning that it's not just the illness that we're treating the whole person and also their family and usually the people around them. So we are addressing the physical problems such as their wounds, but also we are thinking about their mental state, spiritual needs, social and financial issues as well. And who gets it? So, and it can be somebody of any age, a child or a very old person, anyone in between. And it's somebody who has what we call serious health-related suffering due to a severe illness. So the severe illness means that there's a high risk of death with this illness, and this illness is affecting the quality of life of that person, their ability to function, and they might have a high symptom burden. So symptom burden means they're having a lot of symptoms from whatever their disease is. So commonly, these are things like pain and shortness of breath. If we think about wounds, pain will be a common symptom, but also things like bad smell and discharge. And it can stop people from functioning, from being able to walk and move. And the symptom burden can also include psychological problems like anxiety, distress. And the severe illness also causes what is called a treatment burden. So particularly with wounds, this can mean coming for a lot of appointments, maybe needing multiple admissions to the hospital, having to undergo lots of procedures and take a lot of tablets. And this treatment burden also affects the quality of life of the person. And also, when we think about wounds or severe illness in general, there's also a lot of caregiver stress. So the person who is looking after the patient is going through a lot psychologically, physically, financially. So these are the kinds of ways that people can suffer with a severe illness. And palliative care is not just for people who are at the end of life, not just in the last few days or weeks or months. It can even be in the last few years. And we'll talk about that in the next slide. So who should get palliative care? So when we think about these severe illnesses that cause serious suffering, really it can be anything, but here I've written the commonest non-communicable diseases that our patients usually face today. Infectious diseases are also possible, like advanced TB and AIDS, but today we'll just look at the NCDs. So of course, cancer is what most people will think about when they hear about palliative care, but there's actually all these other types of organ failure that will also mean that people need palliative care. So heart failure, lung failure, kidney failure, liver failure, and dementia, so brain failure, or other neurological diseases like Parkinson's disease. And then there's also frailty. So frailty is a condition that is common in very old people, but also you can get it if you have a lot of comorbidities. So things like diabetes and hypertension are not on this list, but they will certainly cause these end-stage problems like end-stage heart disease, end-stage kidney disease. And this figure on the right shows then how people usually end up deteriorating and dying from these illnesses. So this dark blue line is usually what happens with cancer. So people are okay for a long time, and then suddenly they go downhill and die. The red line is usually what happens with organ disease, so like end-stage heart or COPD. What happens is that they have a acute exacerbation and then they go down. And when they recover, they don't come back to their original baseline. So with each exacerbation, they just go down and eventually die. But frailty in this green line is even more vague and unpredictable. It's a very slow process. And so with these organ failures and frailty, it's difficult to sometimes predict, when the person will die, but it's important that we recognize this pattern of going downhill. So we say that palliative care should start at the time that a severe illness is diagnosed. That doesn't mean the first time we meet somebody with heart failure or kidney failure, we're not going to tell them that one day they'll need palliative care. But over time, because these things usually happen over usually years, over time, the focus shifts. So we focus less on the treating investigations or trying to cure, and we start focusing more on the symptoms and the comfort of the person. And this is a gradual process with the patient and the family, where we are trying to focus on quality of life as opposed to trying to prolong or save life, because it will not be of benefit and it won't be successful. And as the person deteriorates and they get more and more palliative care, they go through these different phases. So they can be sometimes stable in their symptoms, and then say they get an acute exacerbation of heart failure, they will become unstable and have shortness of breath. And then when they recover, they will go back to being stable. So they can go between these two for some time, but eventually they will be deteriorating, and then they will be more in the end of life care and then terminal care. And then once the person dies, it's not over, because then the family is going through bereavement as well. So how is this all related to wound care? And what's the overlap? So some of the things that we can think about when we're learning about wound care and you're seeing these patients in practice is, are you treating the patient or are you treating the wound? Is this person dying from the wound, or are they dying from something else, but they also happen to have a wound? How does this affect the decisions around, let's say, doing surgery? What are the other comorbidities this person has? And how does this fit in with their wound care? Certainly in palliative care, we will be thinking about managing the symptoms of the wound, like pain, discharge, offensive smell, itching. And people who have these kinds of wounds, maybe it's a pressure sore, maybe it's a malignant wound, diabetic wound, and I'm sure there are many others that will be discussed. These patients, they have the wound, but then they also have a lot of financial problems, severe treatment burden, because they have to keep coming for appointments. The caregiver burden is huge because they're doing all the organizing, transport, washing the patient, and there's a lot of stigma. associated with wounds as well. So maybe the care of the wound is a lot more complex than we initially realize. And also the patient is very likely to be comorbid, for example, with advanced diabetes, heart disease, and kidney disease. So how do you make these decisions about the wound in the context of these other issues? So deciding the treatment of the wound is part of a much bigger plan of care. So this is not something that you're expected to do alone. This is done working with other doctors, other teams, as well as the patient and the family. And palliative care is giving good basic care. So you don't need to be a specialist or have done any sort of very advanced training to be able to provide basic palliative care. It's something that any doctor or nurse or someone working in a healthcare setting can do. Some of the things are so simple, like being kind, showing that you care, treating the patient and family with respect and empathy. And the small things that we can do, like using the patient's first name, doing a basic examination, providing some reassurance, or giving some simple advice on what they can do, can go a long way for them. And we are lucky because in Sri Lanka, we have a strong community and a culture of caring and usually strong support networks as well. So it's important to remember, particularly for us, that we also need to treat the family. So the family needs to know what's happening with the patient. They want to know the truth about what the situation is, and they want to feel like they're doing their best for the patient. So it's an important role that we play as doctors when we can help them to feel that they're doing their best. They need a lot of support as well, emotionally and psychologically, which can also be provided by other people in their families and communities as well as us. And then how do we treat the patient? So we do all the normal things we do for the patient, but there are a few extra things we need to ask them. What do you want to know about your illness? What is important to you for you to live as happily as you can? Often for patients, it's very important for them that they continue to fulfill the role within the family, like being the breadwinner or looking after their children. And these are really important things to know so that we can help them to do these things as much as possible. Also, they might want to do some things before they get even sicker, like go on a pilgrimage, sort out property matters. And then we also have to think about their symptom burden and their treatment burden. So these things need time. You can't do it all in one go. And it takes time to listen to patients, allow them to ask questions and answer them, and provide them different options for care. And it's also a process of deciding how much to tell them, when to tell them, and who should be told what as well, because we are treating the patient and their family and sometimes have to balance these different things. So you can't do it alone. These things are usually done over time by lots of different people. And there is not really only one right way to do it either. So it's something you get a feeling for. And because this is a session on wound care, I thought it's important to also talk about interventions. Interventions can be something small, like a wound dressing change, and then there can be bigger interventions like surgery or deciding to start someone on an NG feeding or parenteral nutrition. So there are questions that need to be asked and need to be asked regularly. So before we start an intervention, is it needed? For how long? Why is it needed? What kind of education is needed for the patient and the family? What are the alternative options? And when is the review for this intervention, whatever it is? How do we balance what the patient and the family want with what we want to do? And we always think about benefits and risks, but what is the burden of this intervention, the treatment burden, and how will it affect the symptom burden. And very importantly, are there simpler but still effective options? And who are you treating? Is it the patient, the family? Are you treating the wound or the patient? And at regular intervals to think about, should it be continued? Should it be stopped? How do you stop it if that is the case? When and who would you speak to? So these are some of the points that I wanted to make regarding palliative care and wound care. I hope that was a useful introduction to the concepts of palliative care. Thank you very much.
Thank you, Lihini. Tuste, you want to say something?
Yeah, that was a very eye-opening lecture. I mean, I think it couldn't have been done better. It's quite nice approach, and I actually wanted to talk something about the concept of palliative care to this batch, because we being the College of Palliative Medicine, in this program, we actually didn't have this lecture. So this is the first time that we are having this. So I mean, that was a nice approach, and I learned a few things as well. So thank you very much, Lihini. And anybody has any questions? Anybody has had any lectures on palliative care before, and anybody wants to add something? So in the absence of questions, I think either it was too much or either anybody any questions? That was very simple. I mean, yeah, somebody's asking pain management in palliative care. Lihini, are you there?
Yeah.
I
Yeah.
know this is an entire lecture, about half an hour, not half an hour, about 2 hours of lecture. So just a simple thing about pain management.
Yeah, I mean, I think pain management, there's a few different aspects. Like, one thing is that we need to be able to recognize the pain, and then we have to think about, what the cause is. And depending on the cause, there's different treatments. So that can be, pain is commonly a nociceptive pain. Or there can be other types like neuropathic, for example. So depending on the type of pain, we can target the treatment. And then after we start whatever treatment, so there's the non-pharmacological treatments and then the medications we can give. Then we need to have a way of regularly reviewing that pain as well. So, and then depending again on the cause of the pain, sometimes there are other, other options like radiotherapy or surgery or whatever. Kind of, you need to approach the pain in a way like you would any other symptom and see what is causing it and then direct the treatment towards that. But with wound care, I mean, for example, if it's a diabetic foot wound that we're talking about, usually we are using neuropathic treatments like amitriptyline, pregabalin, gabapentin. Pressure sores will be more like the WHO pain ladder. So starting with, basic analgesia and then moving up from paracetamol and ibuprofen, moving up to codeine, tramadol, and then stronger opiates like morphine. So yeah, that's and then sometimes interventions can also help with pain in wounds as well. And then I think people would need a separate session on prescribing morphine and opiates as well.
Yeah, that's a separate lecture altogether. It's pain management. In a nutshell, I can add a little bit on, say, if you are approaching, let's say, a painful wound, you have to first assess the pain using the pain scale. Like 0 is no pain. 10 is the worst pain that they have experienced. So from 0 to 10, where they are like 4, 5, 8, maybe. So that's after that you can use the WHO ladder. So starting from simple things, as Dini said, then going up. And before, say, the procedure of wound, the opening the wound and changing the dressing, about 1 hour before, you can use a simple analgesic like paracetamol or Panadine. Panadine usually is better in this respect. So about 2 Panadines, if they are not allergic to acetaminophen, it will take off a lot of agony during and after the wound cleaning. So that's what we are currently practicing. Any other questions? I think that was answered in length.
Okay. Thank you, Lihini, and thank you, Tusita. So since Dr. Kitsiri is here, let me introduce him. I think he can start his presentation now. So we have Dr. Kitsiri Senanayake, who is a general and endocrine surgeon and the senior lecturer in the Department of Surgery, Faculty of Medicine and Allied Health Sciences of the Rajarata University. And he will be talking about wound dressing.
Tusita, thank you for your kind introduction. Tusita, I can't share my screen again. I don't know whether host...
I will put you to co-host, sir. Give me 1 minute.
Okay, thank you. Okay.
Now you can share this.
Yeah, thank you. I will share where it is, desktop one. Can you see Tusita? Hello?
No,
No, we
it's
can't.
not still shared. Yeah,
Not shared.
yeah. The host is Chitira.
No,
Okay.
I have given the co-host, so
Yeah.
he can share the screen.
Okay. Uh,
Now we can see.
you can see now, no? Because there's a problem with my settings in the laptop as well. Right. Okay. Thank you very much, Palliative team, for giving this opportunity. And thank you very much, Lihini. You are doing a lecture before me, and it made easier for me to proceed with the lecture. And before embarking on the lecture, I would like to add something because one raised a question about acute wound, and we also had a discussion about the pain management. So I have not added anything about acute wounds. Mainly, I discuss about the chronic wounds because in palliative settings, we get mainly the chronic wounds. So just few tips about the acute wounds, not big things, but which are very important when you managing in your practical settings. For example, if you get an acute wound, please remember few points. One is, please wash the wound thoroughly. Second is, please do sharp debridement. For example, if you get the laceration in a forearm, make sure that you wash the wound thoroughly. So in that settings, it comes the pain management, as Tusita said. I can remember one exam question which was asked in MD Part 2 General Surgery. So what they asked was, describe how you suture a wound, acute wound. So people forget pain management, and some people wash the wound before giving local anesthesia. So this happened not only exam answers, this is happening in real world. When a patient comes with acute wounds into your private practice, or maybe the hospitals, peripheries or major hospital, first thing sometimes they do just wash or irrigate the wound without anesthetizing them. So please remember to anesthetize the acute wound first and then wash thoroughly. So then again a question comes with what we should wash: saline, tap water, just water, or whatever. Or betadine or some antiseptic solutions. Remember, washing with saline equals to the washing with tap water. So please don't hesitate to wash the wounds with tap water thoroughly. You can use saline, but don't just get the soap of saline and apply it and go. That's most of the time happening. Pour adequate amount or ample amount of water. I usually put 5 to 6 saline bottles or put tap water to wash the acute wound, because this prevent colonization and then later infection of the wound and reduce the hospital cost and morbidity of the patient drastically. So that's about few things about acute wounds. This is my original lecture. Wound dressing selection. So this is actually a little bit of difficult lecture. It comes with the experience and new knowledge and various other things, right? So for example, if you are asked to manage a patient with dengue fever, or we'll say leptospirosis, there's a definite guideline, definite medications for them. But if you get a wound, it's not like that. They are very diverse. Still in something, some are still in research level. So it is very difficult lecture. So experience and other things very important. So I think after the lecture, Tusita and some other people will join to have some discussion with you all. So if you have any question, please don't hesitate to ask or text. Please, and also please share your experience, which are very important for us as well and for others. Okay. So since these wound care products are involved in a lot of commercial things, I declare that I have no any connection with the drug companies. There's no conflicts of interest. And I always say my student that wound care is not just a care, it's a merit deed, pinak kinade, right? So it's always, therefore, it has been emphasized in all religious and spiritual leaders in every religion. So I will skip those things and I come to this one. This is part of, I think, Bible. There they say they have used wine, oil, and bandages for wound care. And this is some literature from Islamic literature. They have emphasized the importance of wound care. And as you all know, wound care is not just a one person's task. It's a teamwork, as Dr. Lihini very correctly mentioned previously. There are people who need. Give me a second, please. Sorry about it. I'm not in the country. Somebody's tapping the door. Yeah. Right. Sorry, extremely sorry about it. Yeah, it's a teamwork. So as Lihini said, we have a lot of specialists or team we need to take into the wound care. So most important thing I again highlight the psychologist. We don't sometimes pay attention to the psychological aspects of wound care. And nutrition, in case of diabetic wound, the podiatrists, pharmacists, and microbiologists especially is very important, right? So I have seen people comes to me with wounds, especially chronic wounds. They spend a lot of money on wound care. Sometimes they have sold their properties. Sometimes they have sold their jewelries to care for the wounds, right? So in this lecture, my aim is not to promote the very expensive wound care products, but to give some kind of insight into how we as doctors and scientists select rationally select the best wound care products for our patient. So always think about the patient's psychology. So if I ask you all, what is the most fearful event in our life? Or if I ask the dreadful event in our life, most of you will say it is the death. So that's why we care for the people who are going to die with utmost respect and care in our palliative settings. So it is the death. Yet researchers has found that some people fear the lower extremity amputation even more than the death, right? So remember that if someone with the leg wound, they will have lots of psychological problem, even though we don't think about it much. So please refer them appropriately. Right. So on the other hand, wound care incurred a lot of healthcare costs to a country. I don't think we have data in our country, but this is previous data on UK. It says about 4% of wound care healthcare cost is go to the wound care. 4%. Imagine the amount, which is very big amount. But I don't think in Sri Lanka we spend 4% of our healthcare on wound care. What is the meaning of that? That means we are managing the patient. Probably we manage the patients with low resource, very much low facilities. And so probably the patient's not getting the adequate care. So that is the importance of this lecture series we are running for you all. So my lecture today has 3 words: wound, dressing, and the selection. So actually the first part, the wound part, supposed to be done before me by Dr. Tushan. He will be doing it on Thursday. So therefore I will little bit of wound assessment and things like that I will add into my lecture, few slides, so that I can proceed with this lecture. Dressings and selection. So I start up with the second one. Dressings. So the wounds not same from individual to individual. There's no wound is similar to the other wounds, right? If you get one wound from the diabetic patient, and if you get the same age diabetic patient with us, the wound in the same site, yet the wound biology is different. So, and on the other hand, on the other side, there are more than 3,000 commercial preparations of wound dressings. Thousands of dressings are coming day by day. It is commercially highly profitable business. Therefore, companies preparing lots of dressings, right? Medications for wound care, right? Therefore, it's very difficult to select the appropriate wound dressing to the wound, right? Therefore, we need to think about our basics. We need to go back to our understanding of the science, and we have to have a skeleton. We have to have a kind of guideline to select wound care dressing rather than remembering all trade names of wound dressings, wound care preparations, I would say. So therefore, if somebody asks me what is the advantage of that commercial products, I might not know, because there are thousands and thousands of products available in the market. Yet we will classify them into decent categories, and we'll discuss how we can select them. Right. Again, the same thing. So why we use wound dressing? Sometimes we don't have to use a dressing. For example, if we use a surgical wound, sometimes for a thyroidectomy like things, I don't use unless there's oozing. Because when you close that clean wounds, the moisture under the skin, under the dressing, can itself cause infection. Therefore, even UK, most of the time, the acute wounds, sometimes they don't close. Sometimes we put a little bit of a steri strip to prevent gaping of the wound. However, chronic wounds needs appropriate dressing. So their use are to remove or contain odor. For example, we can use film dressing so that the odor will not come, especially in palliative care setting for the bed sores and all. And also to reduce the wound-related pain, to prevent or treat infection, and to contain exudate or probably absorb the exudate. And of course, dressing reduces or should cause minimal disturbance to the patients. I put this slide because there are some terminologies that we should know before going into dressings. So there are things called primary dressings and the secondary dressing. Very simply, the primary dressing is the dressing which is very, and the other wounds, other dressings above the primary dressing, it can be called as secondary dressings, right? So, for example, if there's a wound and if we put, let's say we will put some gel into the cavity, and if you put the dry gauze over it, primary dressing is the gel, dry gauze is the secondary dressing. Or sometimes we put we'll say Metrogel, and above that we can put Acticort or similar. Metrogel is the primary dressing, Acticort is the secondary dressing. Likewise. And there are a few words which you will encounter, but you know already. For example, if you say a gel, we know what gel is, but chemically or in chemistry terms, we should know what they are, and it's easier for us to understand after that, right? So colloid. Colloid mean a type of mixture where one substance is dispersed evenly through another, but the particles do not settle out or separate on their own, right? I think you can understand. Two substances disperse, right? That's a colloid is a common term. So these are the types of colloid available. These are not about the wound products. I'm not talking about the wound products, okay? So if the disperse phase is gas and medium is liquid, so it will form a foam form, for example, in a day-to-day life, it's a whipped cream. If you mix a gas in a solid medium, it's a solid form. For example, your scent or aerosol available. There are a lot of aerosol wound care products available in the market, I think. And if you put liquid into a gas, it causes liquid aerosol like fog and clouds, for example, in nature. And other thing is, if you mix liquid into liquid, it is called emulsion. I think there are wound care products as emulsions as well. What is gel? Gel. So it is liquid in a solid medium, right? Solid gases are the solid aerosol, for example, the smoke. Solid liquid is called sol, like paints, our own blood. And solid is called solid sol, or we call it alloy. The alloys are not, as far as I know, not commonly used as wound care products, but it used for stenting and all that. For example, nickel titanium mixture is called nitinol. Nickel titanium alloy are used for the stents and all that, nitinols, right? So this just terminology. So how we classify the wound dressing? It's very, very difficult since there are so much of wound care products. So I think for the moment, we will remember these names. You know, gauze cotton dressings. Those are also wound care products, right? We can use for wound care. The film dressing, films like Tegaderm, what you've seen in our wards, polyurethane base or polyester adhesive, right? They use as occlusive dressing. So polythene එකක් දැම්මා වගේ එන්නේ නැහැ එළියට. So third one is foam dressings. You know what foam is, right? Solid foam. So they can, foam dressings. And hydrocolloid. This is again not a chemical term. Colloid mean mixture, hydro mean water. So some mixture which absorb water. So you should know that if you use hydrocolloid, it absorbs water, right? Then hydrogels. Gel mean it has water components, so it provides water, right? And alginates are again natural product which actually the alginate wound care products produced from seaweeds, right? So we'll talk about them later. And there are other products. Some people say advanced wound care products, and so this Vaseline and paraffin gauze also we need to add into the list. And there are collagen based and the collagen products such as collagen sheets and granules. There are a lot of natural products like bee honey, papaya, and things like that. As I said, advanced techniques like vacuum assisted vac therapy, we now commonly used. Hyperbaric therapy also we can use. PRP, fresh frozen plasma. We can take the blood of the same patient, centrifuge, get the frozen plasma and inject into the wound. Even this peri-wound ultrasound is not a wound care product. Sometimes we can use it to enhance the blood supply and increase the healing. And there are antibacterial dressings, right? So gauze, films, foams, hydrocolloid, hydrogels, alginates, Vaseline, paraffin, collagen-based natural products. There are several advanced things and antibacterial dressings such as silver, Acticoat, all these things. Okay, so selecting a wound dressing to a wound is, as I said initially, it's difficult. However, we need to think about several factors. I'm not going to talk about all the factors, but for the sake of completeness, I will tell these things. So we need to think about characteristics of the wound, including the location, extent of the tissue damage, that is the depth, and the wound size, pace of the healing, right? You will know the pace of the healing when we teach about the wound biology, inflammatory and modulation pace and all that. Pain, odor, infection, all these things we need to think. And also important things not to forget are the cost effectiveness, right? So this is very important. Since all attendees are doctors, I would say that most doctors actually concerned about the cost effectiveness when treating the patient, but there are other people who treats. What they do is they use, in my experience, I'm telling these things. These people use most expensive dressing, telling the patient that watina ekak tiyena eka dammama hariyai කියලා. So patient sell their properties and get all these high cost products. We shouldn't do this, right? And also we have to think about the patient-centered concern, as Lihini said previously, and many other factors. Assessment of the wound for dressing. This is supposed to be done by Dr. Tushan. I will quickly recap. I will tell. This classification is called time classification. Time, tissue, infection, moisture, and edges. Right. This is given by World Wound Association, European Wound Association. So this is supposed to be the gold standard. So when you see a wound, you see the T, that is, you see whether granulation, slough, necrotic tissue, all that there, whether there's infection, I. Moisture is the most important thing, as I say. In a healing of a wound, you need to think about the moisture very much. Ideally, this should come first. And E mean edges. You need to think about examine for the edges, whether it is rolling, undermine, or any other pathologies going. Recently, I got a wound, not recently, about 6 to 7 months ago. A patient had a non-healing wound. Someone is treated months for this wound, and it was not healing. And when I checked, the edge was slightly blackish, and I taken the biopsy, and it was an ulcerated malignant melanoma. So please think about those things, right? Time is the standard one for wound assessment. So if you see this nice pinkish tissue, these are epithelial tissue, very healthy. Sometimes covering with the occlusive dressing would be enough. And if you see blackish thing, black color thing, these like this, those are necrotic tissue. If you see yellowish tissue, those are slough. There are strings or thick clumps, and sometimes they're mucinous. And also you need to assess these two things when you see a wound. One thing is, if you don't insert this swab inside, you won't see this pocket, right? So when you examine, you gently put the cotton bud inside and see whether there's this pocket. It's called undermining. Please examine for undermining and note down there's undermining in what is this position is 6 o'clock, this is 7 o'clock position, right? Likewise, you can mark it. And here in the center, if you don't put this probe in, you might miss that there's a tunneling, right? So there are two things you need to think about other than time, undermining or tunneling, because this can harbor infection. So whatever you do here sometimes will fail with this infective focus. Right. This is my thing actually. This is how I look at the wound. But basically, this is what is described by European Wound Association, like time, time in tissue, infection, exudate moisture, and basically same thing. But I think that if you start thinking like this, it is easy to select wound care products and manage your wound. What I do is, if I see a wound person, I see how much of slough tissues or necrotic tissues are there in the wound in compared to the granulation tissue. So our ultimate target is to make the wound like this, right? So we are there here now. We have to put wound care dressings and our products. Yeah, we have to use our talents and take the wound into this granulated part and help the patient. And second thing I see is whether the wound is having exudation or dry or in between. So in here, the best thing is to keep the wound in between. So that is called optimal moisture. If you have a wound with very high exudate, those are called weeping wounds. So those not going to heal, right? So if you have a very dry wound, like what I showed previous slide with the black scar, they are dry, they're not going to heal. So we have to have moisture in between. So assess the exudation level in the wound as a second thing. And the third thing, assess whether the wound is infected or not, right? As a doctor, you can do that because there are features of inflammation, sometimes odor, right? The features of infection. And if this goes into systemically, your patient might show the features of systemic infections like fever, malaise, and raise markers like CRP, full blood count, right? The fourth thing I note down is whether this is a kind of a special wound like diabetic, venous, ischemic, malignant. This is the where you can come to the edge actually, right? As you all know, you can have roll edges, everted edges in squamous cell cancers, roll edges in basal cancers, right? Venous edges have sloping, ischemic edges have punch out, right? So, and also you can get the rare infections. What are the rare infections, you know? It is very common to have leishmaniasis in Anuradhapura. The people comes with non-healing wounds after months and months. And when you get the biopsy, it is leishmaniasis. And it can be, what else? Leprosy, although it is eradicated, sometimes rarely you can find. And there are fungal infections, right? So you need to think about rare infections if you suspect. For example, fungal infection, you can see black color or yellow color particles coming. Right. So please remember for the exam purposes, time, T-I-M-E, tissue, moisture, infection, E for H. But when you do your practice or when you treat the patient, I find this slide is important for me. Slide slough to granulation, exudate to dry, infected or uninfected. Or please be vigilant whether this is a special type of wound, right? So the ultimate goal of putting wound dressing onto these wounds is to make the wound nicely granulated and offer the next level of treatment, or the body to close itself, right? Body natural process to heal the wound, right? So this process is called what we call wound bed preparation. So this is very important. That is the whole idea of putting wound care products, right? So wound bed preparation is very important. So all our SHOs, registrars goes to the theater and do wound toilets, remove necrotic tissues, and do some kind of wound dressings in the wards. And we send the patient once the wound bed is prepared to the outside community. And since we don't have wound care community settings like in UK or the other countries, so people go here and there, and then they put wound care dressings from some people, and they appreciate that since the wound bed is prepared by the team at the hospital, wound very quickly heal at the peripheries. So people admire the people who put the dressings, but not the person who cut the wound. What they say most of the time, I heard is දොස්තර මහත්තයා කකුල කැප යන්තම් මෙහින් තමයි හොඳ කරගත්තේ කියලා. So we need to think all these social aspect, because I don't have any time to tell those things. So when you practice in the outside, not to make any clashes with the people, but talk to the patients and explain the things, take a little bit of time. So it will improve a patient's satisfaction and trust with the doctors. So which is very important in the nowadays. So another term that I need to tell you before going into the next aspects is the biofilm. So biofilm is a tiny or very thin film formed on chronic wounds, which delays the wound healing. So if you want to heal a wound, you need to break the biofilm. So there are a lot of research about biofilm. And if you want to do a PhD on biofilm, you can do, because that is such a interesting area, right? So therefore, the wound companies are chasing behind this biofilm. So because if somebody can eliminate easily the biofilm, so they're going to get a lot of commercial benefits. So basically, what is it? So it contains microbes, polysaccharides, protein, damaged DNAs, and all that, making a tiny film. It says about 60 to 70% of the wound having the biofilm, right? So the problem is it's very much resistant to antibiotic than free bacteria, right? So remember, it delays the wound healing. And the common organisms which contributes to form biofilms are Pseudomonas, Staph aureus, and Enterococcus species. So if you see this wound, you might see this area yellowish. So what are they? They are slough, right? So sometimes this biofilm also appears as slough, right? If you see very carefully, you can see a transparent thin layer that is the biofilm, right? So this area you can get some slightly necrotic area. These are slough and these granulating tissues. A little bit dark red, and I think there's not very healthy granulations, not healthy granulations. So this is a wound with biofilm, right? So we need to break this biofilm in order to heal the wound. Right. So as I previously said, I'll go back to the slide. So you need to think about these 4 aspects: slough to granulation ratio, exudate to dry, infected to non-infect, and you need to think of whether this is a special kind of wound, right? So I'm going to discuss about slough wound, right? In the same time, I would like to say you that the wound can be sloughy, exudating, and infected. It can be sloughy, dry, non-infected, or dry with the underlying infection, or whatever the combination of above. So when you keep selecting the wound care dressing, you need to think those things, right? So we will see what we can do for sloughy wound. So if you find a patient, your patient, when you see the wound is the base having slough, so how do you remove this thing? What are the dressings you recommend patients, right? Of course, this patient, I would do surgical debridement. So what we can do: surgical debridement, mechanical desloughing, biological desloughing, or enzymatic, right? So surgical debridement, use the sharp blade or scissor. And the important thing is, if the wound is having granulation tissues as well, take care not to damage the granulation tissue. What I see most of the time in the theaters, when we send the patient to wound care, so whole wound is debrided, so the granulation tissue also damaged, right? So it gradually goes down, down, and down, and make a huge ulcer up to the bone or tendons, making it more difficult to cure. So take sharp instruments, carefully remove only the necrotic or sloughy tissues. There are other methods like hydrotherapy. There are commercially available machines which inject the fluid or the water at the same time it suck it in. Simple physics, but expensive machines. But you can use syringe. Those machines are called Vasajet. Or simply what we call is, we ask patient to have a shower before routine dressing. That's basically mechanical debridement, very helpful. And other thing is called wet to dry dressing, very simple. You put a saline soap or hypertonic saline soap, sterile dressings onto the wound, and keep several hours and remove it. So the disadvantage is we have to do this 3 to 4 times a day. However, very cost effective, and it's sometimes very important to remove the slough. So we can ask patient to do this. If you have a patient, you advise patient to do, please do this every 2 hours and like this. So they nicely do it. It's less costly. And other thing is the biological debridement, again, very difficult in Sri Lankan settings because of the complaints of the patient. There are commercially available lava or panu, and when you put them into the wounds, they eat the slough tissue selectively without eating the live tissue. So it's very important, which we can't do by ourselves. So they say about 30 larvae each, approximately 1 gram of slough a day, right? So it's painless, but patient complains tingling sensation. It's virtually impossible to put in our settings. I have tried, but I don't know the other. If you explain the patient, some educated or some people might willing to do that. Think whether you like it or not. Right. So these are the commercially available larvae. So they not only eat the slough tissue, but also they have some chemical debridement action. They also said that the larvae going to change the pH of the wound, and also they release growth factor like chemical, and also they ingest microorganisms, right? Other thing is enzymatic desloughing, right? So we said surgical, biological, chemical, right? Enzymatic, those kind of slough removal. So there are a lot of enzymes available to remove slough. You should remember that slough is protein, basically mainly protein. So any proteases can deslough or damage the slough tissue and helps to remove them. There are commercially available things, collagenase-based products like, as far as I remember, probably Iruxol. It's about, I think, more than 8,000 rupees. It's a toxin from Clostridium taken, but I don't think it was very effective desloughing than the surgical desloughing when compared to the cost. And there are papain-based product. The papain is an enzyme found in this papaya. So you can use papaya, but it's better to have commercial preparation. They do it Israel way and easy to use way. So I think fortunately now in Sri Lanka some companies producing papain-based wound care products. If you search, you can get in very low cost. It's a good thing, but it was not there several years ago. It was taken from other countries. We had a lot of we have a lot of papaya trees in Sri Lanka, but yet we didn't use them. Previously, we as senior registrar during the senior registrar period, we use papaya for the wound care product. We ask patient to bring, and they bring, and to some extent we manage it, right? And papain urea complex, again available in the market. Remember, if you see sloughy wound, there are enzymatic product as well. You can search in the market and take it. Don't remember them and don't support the companies. So there are things, enzymatic things, so many things. If you see the research, papain urea, papain chymopapine, right? Collagenase. So many things, right? So, okay. And also the simple thing that we can use, so for the sloughy wound, as I previously said, is hypertonic saline, which is available in the wards, very much low cost. If you put hypertonic saline dressings with the gauze, and it will loosen the tissue and helps to deslough. The other thing is bee honey. It's very effective. in UK and other countries, it's available for use in wounds. Those are actually Manuka honey from New Zealand. We also can use our bee honey from Sri Lanka, but the problem is there's a risk of botulinum spores. We can remove that by gamma radiation. So this is one of my publication on Sri Lankan bee honey, which is very effective, but we have way to go to produce commercially. Again, remember these things: slough, exudate, non-infected, or important things, right? We talked a few things about how to remove slough from a wound. Right, if you see an exudating one, right? If a lot of water, what will happen? So this wound has a lot of exudate, so watery fluids coming out. So what will cause what is the problem? So it causes maceration of the surrounding skin. Skin is macerated, pegula. So this edge is very important to fill the wound with epithelialization. So if there's a lot of fluid weeping, so this edge will macerate, preventing from healing, right? So therefore, making the wound keeping the wound in the optimal moisture is very, very important. At the same time, please remember, wound management is not only the wound management, it is the management of peri-wound as well. So peri-wound management is very important. So if you have a patient with wound, please remember the peri-wound as well. Wound, peri-wound, and then the patient as a whole, right? So if you have a wound with exudate, you should put a wound care product which absorb your exudate, right? So if the patient has high exudate, it causes malodor, right? It increases the wound pain. Sometimes cause protein loss, fluid electrolyte imbalance, delayed healing, local wound infection, and probably you have seen in the ward soil clothing and bedding, making it very unpleasant, right? So what are the things we can put? These are alginate dressings. It absorbs a lot of fluid, right? Commercially available. These are produced from seaweeds. So think about the instances where you get high exudating wound. So in my setting, most of the time what I seen is infected paraumbilical hernia. So if you keep the wound open, there are a lot of fluid coming out. So what we actually do is we don't put anything. We just put dry gauze. So it absorbs water into the dry gauze, and if the dressing is wet in 1 hour, we remove the 1 hour and put a new dressing. And likewise, we shouldn't allow to wet the dressing through and through. It promote infection. So dry dressing also important, remember, to absorb fluid until it comes to optimal moisture, right? So as I already said, the weeping wound or the moisture wound has high chance of infection. So there are antibacterial dressings combined with alginates or other fluid absorbing wound care products or colloids, like you can actually have hydrocolloid or hydro. Okay, can you put hydrogel into highly exudating wound? You can put, but when you put gel into highly exudating wound, what happens is it add more water. So it causes peri-wound damage and it delays healing. So be careful of putting gels into high exudating wound. So you need to put whatever the things you absorb, remember. So what is Ketoxoma iodine dressing, right? So when you get iodine dressings, there are two types iodines, povidone iodine, which is commonly what you call betadine, or Ketoxoma iodine. Those are two forms available, iodine forms available. So Ketoxoma iodine commercially available as Idozorb, right? So Ketoxoma iodine is, basically ionized, so it absorb and swell and later release iodine. So it has a very good absorption capacity, and it has very good antibacterial activity as well. So you can imagine that slide previously. So if there's a slight exudating or moderate exudating wound with evidence of infections and slough, probably you can use Idozorb or the Ketoxoma iodine preparations. However, please careful when you use in pregnancy or lactating women or with thyroid diseases, and some people are, iodine sensitive. Remember thyroid diseases and pregnancy and lactation. Basically, don't use. Foam dressings. So it can be produced from various materials. So it can be used to absorb exudate, low to heavy exudating wounds. So I'm not going to tell all commercial preparation. If you go to the internet or Sri Lankan markets, what is available, you can see. But you should know is if it is a foam dressing, it absorbs water. There are foam dressing which impregnated with antibiotics, antiseptics. So like Cilla or any other things. So it, depending on your wound, you can choose your wound care products. These are some of the things. I'll go there. And there are some gelling fibers. When you put these fibers into the wound, it make a gel. Even foams can make a gel, because when you put the gel, it absorbs and make a gel. So one important thing is, once it makes gel, please remove it. Otherwise, it's like, putting a gel into the wound and cause a peri-wound maceration. So gelling fibers, the commonly available one that I can remember is Durafiber. So when you put into the wound, you can make a gel-like thing later after absorbing the exudate. So you have hydrocolloid. Again, gel forming is made of carboxymethyl cellulose. So it's important for moderately exudating wound. So these are some commercial preparation. And also you might you must be encountered this one, collagen powders or collagen sheets. Important thing that you should make is collagen powder. Not good for infected. There are collagen powder with antibiotic. So you can search in the net and you can find available one. Collagen sheets are used for ribbons. Use the really